Hello and welcome to the 2020 Influenza Season Nursing RS Staffing Analysis. My name is Stephanie Kopit and I will be guiding you through this presentation. According to the CDC, influenza is responsible for 18 to 26 million medical visits, 410,000 to 740,000 hospitalizations, and 24,000 to 62,000 deaths in America. It's important to note that this is an estimate and these are ranges and it goes from year to year. Obviously, 2020, we're going to have more deaths with COVID. And being that the CDC, if you investigate further into COVID numbers, you can see that of all COVID deaths, 2/3 of those also tested positive for influenza. So what's important to note this year is who is most vulnerable. Obviously, you have your immunosuppressed individuals that are at risk, but also what age are these individuals and where are these populations concentrated? So we're going to look into that, and we're also going to look at when to send staff, how to send staff, and where to send staff. So this is a staffing trajectory, so we want to know where is our problem children and how do we address them. From the analysis for 2018 influenza season, you can see that 3/4 of all influenza deaths were over the age of 65. Now on the right in the red, those are your top 10 worst states. You can see California is number 1. On the bottom, you can see dark blue is the majority of people over 65, so higher populations of 65, where light blue is lower populations of 65. You can also see that red and big dots means more flu deaths. Yellow and small dots means less flu deaths. So from the map, what's easy to see on this map is that California has a big red dot and it's dark blue. Alaska is light blue and has a little tiny yellow dot. So those are your most contradicting states. You have Alaska, which has the least amount of deaths, and you have California, which has the most amount of deaths. You also have contradicting populations. Now, as you can see, the blue states, which has more people over 65, the most people over 65, they are also correlating with red and orange big dots. So that means that the more vulnerable populations you have, the more flu deaths you have, which is to be expected. What is important to note is Pennsylvania. Pennsylvania has, 2,229,861 individuals over the age of 65. And they had 20 more flu deaths than Florida, which had 4,064,376 people over the age of 65. So Florida had a significantly higher, almost double the population of Pennsylvania, yet Pennsylvania had 20 flu deaths more. So it's something to keep in consideration when you're addressing staffing. What's also important about Pennsylvania is it does staff RNs higher than average, which will be noted on the next slide. Due to this analysis, the hypothesis is that states that have greater concentrations of individuals over 65 years old will have increased risk of flu death. Moving forward, we're going to be using 65 and over as our vulnerable populations. That's not to take into account for high risks of immunosuppressed individuals, but due to the data that we had at the time of the analysis, this is what we're moving forward with. As you can see on the line graph on the right, these are the last 5 flu seasons trended. So week 1 would start at week 40 and week 52 would be week 39 of the chronological year. So we're starting around the last week of September and going to the next September, which is when you see influenza clinics and vaccination clinics, September 1st is typically when you get your influenza vaccine available for the year. And that's when they're trying to predict which flus are going to be the most problematic in America. So based on this, you can see that in 2017 and 2018, you have a greater peak of flu deaths. You also have an earlier peak, whereas the rest of the years trend a little later, and they're a lot shorter, staying around the 500 mark. In 2015 and 2016 was a low year. So typically what they say for this is that they matched the vaccine better in 2015 flu year season, 2015-2016, and they did not match well to the 2017-2018. So looking at these results, flu vaccination is important, and it's something to consider when you're doing preventative care for influenza along with hand washing drives. So on the map you can see nursing staffing ratios. So it's the number of nurses per 100,000 people population. So in California, from the previous slide, we noted that they had the most deaths, which you can see here because it's red and big, the dot, which is carried over. So instead of having the states colored by population of individuals over 65, now the states are colored in nursing ratios per 100,000 people. So the lighter the state, the lighter the amount of nurses, or the lower the amount of nurses, and the darker the state, the higher concentration of nurses per 100,000 people. We already noted that California was a big problem, so we need to address California. California staffs nurses at approximately 664 RNs per 100,000 people, and they have the most flu deaths and they have the highest population. Obviously, California is going to take a priority in staffing. Pennsylvania staffs nurses over 1,000 nurses per 100,000 people, which is usually good. So in Pennsylvania, we have to look at, are the flu deaths in urban areas where there's hospitals, or is it more rural, because Pennsylvania has a rural area, and are people not having access to healthcare? Because something is going on in Pennsylvania where there's a shift in flu deaths per population. So either it's with the actual healthcare practices or access to the healthcare. We have to look at that and we have to address that and staff accordingly for that. So do we need more rural clinics, or do we need, where do we need to send people? Pennsylvania should be broken down further to address this. Which is important to note. On the slide, you can see your best outcomes, your best states, which typically have better outcomes, and your worst states, which typically have worse outcomes. It's important to note these, because if you're sending nurses out, when you're going to the floors or the clinics or wherever you're needed, or nursing support staff or pharmaceuticals or wherever you are, it's important to note, are you going to need more people because there's less technology, or can you send people there because there's not available resources, and do we need to divert people to other hospitals? So these are things that we need to know and how to plan. Now these are your problem states. What makes a high priority state or a problem state based on this analysis is your high vulnerable populations, your high flu deaths, and low RNs per 100,000 people. Now, Pennsylvania and Ohio both have staff over 1,000 people, but the rest of them in this have under 1,000 per 100,000 people. So they could use more nurses per 100,000 people. Would be easy to address, accommodate. But what's not accounted for, other than Massachusetts, is the outcomes of the state. Massachusetts was actually moved to the next slide due to the high outcomes and the high nurses per 100,000 people. So because of that, we moved it to medium priority versus high priority because they have staffing available, but something's going on where it's not meeting the needs of the people or the population. What's not accounted for in this analysis is pollution and air quality, which might need to be addressed further along. Here are your medium priority states. As you can see, we talked about Massachusetts previously. Another one to note is Minnesota. Minnesota is considered the gold standard of healthcare. They founded the Mayo Clinic. They tend to be the state that people look to for that gold standard. So even though Minnesota and Massachusetts are on these slides, both Minnesota and Massachusetts are known for their healthcare. They're known for their nursing staff. They're known for how to treat their nursing, how to overcome difficult situations. For whatever reason, they're having increased flu deaths, so they are on here. But they're not a high priority due to their current medical abilities. The other states on here, it's important to note. One key thing about Maryland is that Washington, D.C. was reported separately. Washington, D.C. has numbers similar to Massachusetts, and they have very high deaths. So Washington, D.C. may be an area that needs to be addressed. However, it wasn't reported on a state level. So breaking down state information into local areas, counties, municipalities may be needed for where exactly to send staff. It's also important to look at previous records on where we sent our staff and evaluations of those years and how we did and how effective we were at addressing the influenza need. These are your low priority states. What's important to note about some of these states is they're very rural. People are far apart, so they're not interacting, they're not spreading things. Like Alaska. Alaska is very low in Wyoming. North Dakota, South Dakota. North Dakota and South Dakota are known for their healthcare. However, they are known for being very vast, not having big urbanization, and so people are not spreading it as much. But there might be a need for more nurses in these states other than South Dakota and North Dakota. Alaska has the least amount of nurses, and maybe access to healthcare is part of why they are not detecting the flu. It's hard to say, but there are other factors going into this, but this analysis really ran with flu-related deaths. So these are your lowest states, your lowest priority in relation to flu-related deaths. Another big thing to consider with all of the states is that you are going to have, in addition to the population being sick, you're going to have nurses being sick. So you need to staff your med-surg floors, your critical care floors, your emergency room floors, your clinics. But in addition to that, you're going to have staffing on reserve for your average units like L&D, labor and delivery, mom and baby, GI, because nurses will call out even though they are, most of them will receive the flu vaccine because it is a condition of employment, or they must wear a mask to prevent the flu. but nurses still will get sick, and during flu season, that's where you see the majority of your respiratory illnesses. Whether it's because people are inside or school's going on, for whatever reason, you see an increase in your fall and winter months for respiratory viruses. So this is our conclusion. Your key states, again, were the ones with populations over 65, below average populations of nurses, and higher than average flu deaths. The key number that I noted in doing all of my analysis and evaluation and comparing to other countries and looking at what's going on other than nursing shortage is that if you can staff at about 1,000 or around 1,000 or above 1,000 nurses per 100,000, it tends to bring up your outcomes and decrease your deaths. Now, it's not in gold and it's not in stone, and yes, there are states that prove that wrong. However, for the majority of states, it seems to really help. So if we could increase states' nursing ratios that are below 1,000, that's one thing to look into. Like California, I mean, around 600 nurses, 664 RNs per 100,000 people, and yet they have the most deaths and they have the most vulnerable population. Interventions, again, we need to have a flu vaccination September, October, November. That's when we need to administer our flu vaccines, do flu drives, get the knowledge out to the community in addition to hand washing and covering your cough. These are things that we do every year. Very important this year with COVID. Going forth, January, February, March is your typical flu deaths. Again, with COVID, we might see a peak before that. Swine flu was 2009, and your peak was November, December. So it's something we need to be ready for. It's something our hospitals need to be anticipating. They need to have reserve staffs. They need to be ready to go. What really is important is evaluating nursing RS staffing and trajectories is to look at the previous years. I did not have access to this information, so moving forward, we need to evaluate that with this analysis, cross-analysis. Another thing that we need to look into and plan for is comorbidities with influenza. The main analysis was run on solely deaths from influenza. However, influenza could have been tested positive with other things such as leading to pneumonia or heart attack or stroke or some other event that being sick with influenza and decreasing oxygen could lead to another form of death or possibly a fall and a death because you're out of balance, dehydrated, death from dehydration, which all started or rooted in influenza, which is not taken into account in this analysis. These are the limitations of this study. It's important to note that I am a registered nurse, so I have a bias there. It's also important to know that I've seen the effect of staffing on nursing outcomes or health outcomes, and I know firsthand how having 4 to 6 patients on a med-surg floor is a lot easier to handle than 11. And when things go wrong with 4 patients, you know, a nurse can address that situation, get that person to where they need to do, see that indicator before it becomes a problem. So if a nurse has time to actually look at and trend patients before they become problematic, which is how nursing staff and increasing nursing staff ratios is effective, then you have better outcomes where you notice, the vitals are slightly off, or something's not going on right with that patient, but you can see it firsthand because you're actually in the room with the patients, observing them, and able to trend vitals, and you're not trying to administer meds to 11 patients with treatments and everything else going on. So that's one thing to take into account. Another thing to take into account is we're sending staff and addressing what needs to be done on the floor. So talking to the hospitals would also help. Like, would a med tech that solely passes meds be effective, especially like in nursing homes, so that nurses can do other parts of their job and manage the healthcare? These are things that need to be addressed, but the things that are noted in this are time, money, availability of the data, public databases, and accuracy depending on how the data was collected. These are all limitations I had, and I thank you for your time, and I hope this helps you in staffing for 2020, and I hope that this addresses any needs or concerns that you may have had. Thank you.